Dr. Usha, thanks a lot for willing to come out. And I just want to understand, now that you've been through this journey, first, can you just talk a bit about what's it like right now on the ground in terms of cases in Mumbai, right? You're at?
Yeah. Okay. So I work at the Department of General Medicine in LTMMC. So we are right now heading we are in charge of the COVID wards, and we delegate the duties to the other departments who are helping us out as well. So it's actually very different. It's a very different scenario right now and 2 months later. So I'll give you a picture of
Yeah.
both. So when it started off, my hospital, especially Bombay, and especially my hospital, was in a very big fix because we were getting an influx of cases that were we're used to the influx of cases because Sion Hospital is in general
Yeah.
magnet for all the cases from all over the place. But since the COVID started, we weren't able to handle the influx of it. Was just a crazy rush of patients coming in from Dharavi, Govandi, and everywhere else, and so much so that we were completely overwhelmed by the number of patients who were coming in, not able to handle the numbers. We didn't have enough wards, and the whole referral system, they weren't used to it because there maybe 1,000, 2,000 new cases every day. So it was a big mess. And at that point of time, there was people were new to the concept of using PPs. So we initially used to get half PPs and then wear masks, and then we started realizing the importance of wearing PPs all over the place and not just in the situation when we're more likely to meet a COVID patient. So you must have come across a lot of videos actually about Sion Hospital. There was a lot of bad media about it at that point in time. Videos about dead bodies not being cleared out, videos about the emergency ward being completely full, and all of them were 100% reality. It was the 100% truth. So eventually we got better at it. The administration started opening a lot of new wards. The reference systems, they opened the BKC COVID care center, which had about the capacity to handle more than 500 patients.
Yeah.
So it got better. Right now, we're in a situation where it's still as crazy as it was before, I would like to say, but we're way better at handling it. So we don't. It's still very tough because the type of patients we get are so much they're in a much worse situation than the rest of the patients around a lot of other hospitals. We get all the serious patients, we get all the patients, we have quite a lot of deaths still. We're still dealing with the new medications. It's a very good thing that I'm working in this hospital because I've gotten to work with all the expensive medications like tocilizumab and remdesivir and everything, and we're able to provide all of that for the patient for free, which is an amazing thing, and I never expected that to happen. But overall, it's been an amazing and crazy not an amazing in like a it's an amazing in a way that I never expected everyone to be able to handle it in the way that they did, especially my department.
Yeah.
My department is working at least 5 times that what they usually would. We're getting all the help from all the other departments possible. We have people working in sequence. We have at least we have 7 wards. We have an ICU, and we have it's a miracle.
Yeah,
So
no, it's overwhelming to hear this, and I think this is what I've seen happen generally in any medical fraternity. This organized chaos that suddenly becomes into a system, and everything just falls into place. We've seen mass
exactly.
RT, we've seen loads of cases, and suddenly everything falls into place. So, firstly, hats off to you and your rest of the team over there that's handling this. Some of the things that I want to ask you is that uh, different hospitals are having different approaches towards COVID-19, and not all hospitals are seeing the kind of volumes that you are. But when you talk about now you're figuring it out and you're able to control this, what are the key learnings that you're getting to see, either in terms of profiles of patients or how are you segregating them, and are you advising a home quarantine to some people, or are you admitting them into ICU, or are they keeping them on isolation wards? And now that you've tried a lot of medications, and I'm happy to hear that they were provided free of cost, and some which are known to be very expensive. But if you could give us a few insights, because I think that is very useful for other hospitals. Like I'm here in Bangalore, and we're now seeing a peak, right? And maybe these kind of learnings will help other hospitals to pick it up. If you had 4 or 5 key learnings of what you're doing now that it's able to be a little more organized and streamlined from when it was chaotic, what are the new learnings that you had, and what were the insights?
Okay, so first of all, starting from the OPD and the emergency basis, we triage the patients who come in. The patients who just come with the mild symptoms, we give them an option. Either they have the if they stay at home and they have the facility to have, they have their own room which has an isolated bathroom and everything, we ask them to just stay at home, advise them that, tell them that it's not exactly necessary for them to get tested, because we, no one at this point in time has the facility to test the thousands of people who come in just with cold and cough and fever, even though they're very likely to be COVID unless proven otherwise. So we tell them to stay in their house for about 14, 15 days until they feel like they're completely normal. And then if they want to get tested outside, they could do that.
Okay.
Second, they're the patients who are symptomatic and they either have a low BP, they have a low blood pressure, or they have a low oxygen level, which is something we screen for almost every patient. We get their X-ray done, we get their, we check their saturation. Everyone is trained from all departments is trained to look at their saturation level, auscultate them, get an X-ray done, and we know the basic bad signs of a patient who's going to turn serious.
Let me
And we
sorry, just to interrupt you on the oxygen saturation. Have you come up with a particular number below which you feel that this is more likely to, below 90 or below 85? Is that something like that, or what is low?
below 95 is someone that we look for, plus people with X-ray changes. Below 95, usually we prefer. See, what we used to do before when we didn't have zero, we had zero beds in our hospital, is that we tried to refer those who could actually manage to go to another hospital to those the dedicated hospitals like Nair. But then we now have a few bed. We have enough beds to actually take in the people that we feel like will require oxygen, and everyone below 95 will at some point of time require oxygen, because they the trend is that they tend to be stable once they walk in, but then they do get worse eventually. So what happens is that these people, especially if they have X-ray changes or they have tachycardia or they have basically a pulse rate is really high or they have a low BP, we tend to either admit them, and the rest of them we advise them to go to the BKC, go to BKC to get admitted, because there they have the facility to provide tablets and a low level of oxygen, which means if they can just manage on a nasal prong or something, they can be sent there instead. So
Okay.
that's what we do. That helps clear off a lot of the population who's coming to the OPDs in emergency, and we manage to triage the patients who come in. So I think that's the initial mess that we faced during the COVID, the initial few months, was how to deal with the influx of patients who were coming in, because it was just ridiculous. It was there used to be a huge line where people used to just have saturations of 60, 80, everyone standing together in one line. And the weird thing about COVID pneumonia is that even if you have a really low saturation, you could still walk in for some time and look like you're completely normal. That's a weird thing that we noticed only in this disease. I don't think we've seen that in a lot of other diseases. So those were the kind of patients. The most important thing is triaging and trying to send them to a facility that they would be best treated, because otherwise the beds get wasted in the place. Because here at Sion, we have a lot of, I think we have a good enough level of expertise to handle a lot of cases, plus ICU beds. So we only taken those patients who we feel like we really, really need our level of expertise. The rest of them go to BKC. So that is something that really we learned, and I think that helped us manage the influx of patients. Secondly, in the wards, everyone who has any sort of respiratory distress or fever or any like loose motion, anything that's suggestive of COVID, goes straight to the isolation ward. So we managed to make that clear. Like we have a general ward and we have an isolation. We have two complete sets of parts of the hospital completely segregated. So we have the isolation wards even for surgery and orthopedic patients and for OBG patients separately, so that even if they do incidentally turn out to be COVID positive, they can be taken into those wards as well. And then once they get admitted into the ward, those who require ventilation or anything go straight to the ICU, which I'm afraid to say that we don't. That's also a very hard decision to take, because there's so many patients who require it, but there's so few of the ICU beds and the ventilators available right now. But I think we've been helped out a lot. We've got a lot. We've got tons of ventilators on donation. We've gotten a lot of high flow nasal cannula machines that have come for been donated to our hospital. So that way, yeah, a lot more patients are being handled in the ward than we would have expected.
Okay.
So
No, I think, yeah. So I think this is very useful, Dr. Usha, because I think I see a very clear flow chart over here that a lot of other hospitals can also follow. And especially, I think what I was curious about is whether everyone is being tested, because that is kind of the time bound roadblock, right? If you have to do an RT-PCR, nasal swab, oral swab, then how do you manage such volumes? And I think I see the logic here that if anybody has symptoms and you're looking at saturation, low BP, and those kind of parameters, and you put out a protocol that you are either home quarantined if you have this saturation and above this you're okay, or you need further care. I think that's a good mass volume strategy that I would say, that you're implementing. And then also after that, putting people in isolation in general, and those kind of wards. Now, before I start asking about your personal experience with COVID-19, I'm a little curious to understand that ICMR has been floating out so many medical, protocols, and they keep changing very frequently as well, right? And we've
Yeah.
seen I mean, the first time I've ever seen Lancet withdraw an article, but there are a lot of debates that are happening with HCQ, with dexamethasone, with remdesivir, and then your fluvipiravir, and now these immunomodulator drugs, and I think one important insight that you can bring is if you can tell us what do you think is working and in whom, based on your experience over here.
Okay. So I'm one of the low-level residents working in this. So I'm going to just tell you how much I
Sure.
have figured out so far. Is that the steroids, the heparin, because
Okay.
COVID is known to cause a lot of coagulopathy. So the heparin, the steroids, have definitely known to cause a difference. And
Okay.
we actually have conducted a study on tocilizumab as well in my hospital, and we found it to be effective.
I'm sorry, on what?
Tocilizumab, the
Okay.
injectable tocilizumab, we found it to be effective, and there's a range of people who that is effective on as well. It's a clinical profile. People who have lung involvement, but they have an oxygen level that's not too bad, but they still require quite a high level of oxygen requirement, and those are the people who we usually choose for this drug. And we've just started giving remdesivir right now, like since the
Okay.
past 1 week. So I won't be able to give you a very good idea about that because I haven't been working in the ward for the past 1 week. I haven't been working. It was my off COVID duty
Got
since a week. So
it.
I can give you a better, in maybe in the future, I can give you a better idea about the effectiveness of remdesivir. But for sure, steroids, heparin, and tocilizumab have definitely helped. And the rest of it, yeah, HCQ on as a prophylactic, maybe I've seen a lot of difference, but not as a treatment for patients who have been admitted for the same. So
HCQ and azithromycin combination is not really.
you definitely that's not used very often. HCQ is used for almost everyone who has a normal ECG in my hospital. Uh, but yeah, antibiotics in general, yeah, they are, most of them seem to require it because a lot of them have superimposed infections. So
No, I think this was useful, and I think we're seeing a lot on DEXA, a lot of literature that's coming out on
yes, a
dexamethasone.
lot of, and I've personally seen steroids work wonders.
Yeah,
So
steroids, because of its anti-inflammatory response, it quickly
yes,
reverse a lot of these.
and I have to emphasize that this is a disease that I think I've seen so many infective diseases, but this is a completely different chapter altogether. Very different virus, very different clinical parameters.
Yeah.
So
And I think
lots to
because
learn
it's
from this.
mysterious, right? It deceives, right? You appear normal, like you were saying, people are
Yes,
normal, but they have dangerously dropping oxygen saturation levels, and
yes,
we have seen dropping saturation levels and people are not even oriented, but here they
yeah.
appear to be normal. So
They walk. It's a miracle. They walk to you with a saturation of about 65. I've seen a female walking with a saturation of 65,
God.
and yeah,
Yeah, you
it's just
almost like
heartbreaking.
that their saturation device is broken rather than you'll try.
Yes, for sure. The first two times I definitely thought it was broken.
Yeah.
Yeah.
Okay. So I think no, these are very very useful. I want to just ask one thing. You may not have the exact data, but we have data from Bangalore that says majority of the patients going into one of our leading hospitals, if they go into an ICU on a ventilator, more than 90% are not surviving. But what are the kind of
Mhm.
numbers you're seeing there at Mumbai?
No, people who are intubated and put on ventilators have very, almost very zero chances of survival. Those who are on NIV, who are good enough to be put on an NIV, they have, I say, a good enough chance to survive. Not
Okay.
all of them are. A lot of them have actually recovered under circumstances that we did not expect them to. So
Okay. You see
that's a
people
good
on
thing.
NIV? the chances have been good, but those who have gone into the ventilation, yeah,
Yeah, who have been intubated and gone into complete ventilation, they have very low levels of survival.
why is that? Do you have any understanding of that? I know that's a long. I know people have prolonged stay, and then that leads to tracheostomies and ventilator-associated pneumonias and other complications and organ failures and all of that. But is there anything specific that you've seen as a reason why there is such a poor recovery in patients who are going into the ventilator?
No, I secondly think that that's the level of, after some point of time, that level of damage to your lungs just does not let you get out
Just
of it.
okay, okay,
So I think more than the intubation actually causing problems, this is just my opinion.
okay,
I think it's just the level of damage after which you can't uh, really help the patient recover. So we've had the high flow nasal cannula actually that's been helping a lot. I've personally experienced that it helped a lot. That's
okay,
something that it's the first time I'm using this, and I think a lot of other doctors around the country have been using this for the first time for a condition with respiratory distress, and we
okay.
found it to be pretty useful. But yeah, the ventilation not so much.
Yeah, that's a concerning thing, and I hope things get better, because generally, I've also worked in the ICU, and many times there are ways to get people out, and the other problem that's happening now is the cost related to ICU stays, right? Anywhere ranging from 10 to 25,000 per day, and average stay being 7 to 8 days, and with such
Yes,
low chances of recovery, it's actually a very difficult decision both for clinicians and the relatives and the patients to take such decisions and manage it. So I think it's a very very challenging times for doctors, and this disease has really put us through a lot. But now I will focus a bit out of my personal curiosity on the medical side. But I'd like to ask, Dr. Usha, I know you've battled COVID and you're out now, but how did that happen, and how did you suspect that to happen, and what do you think that I'm sure you were exposed to a huge viral load, but if you could talk a bit about your experience in that, that would be
And
great.
and before you answer that, I want to say on behalf of everyone who will be watching this and is watching this that we are very proud, and such a young doctor you are, and I heard from your sister about this while we were talking, and this was just some other conversation, and I asked her that, hey, your sister is a doctor, right, and in Bombay, and then this conversation happened, and I just want to say that doctors like you make us feel very very proud, and we
thank
are
you so
very
much.
thankful. So yes, please continue.
Thank you so much. Uh, so I had been working my hospital had seen COVID for about 2 months, and I was posted in the Seven Hills Hospital, which is a COVID hospital. When I actually got it, I just finished my 2 weeks of the duty, and I'd say I think we took all the precautions, but at some point of time, I think you just can't avoid the infection from happening, because I was using my full 100% PP and everything. So I started getting a cold, and I thought it was okay because I keep getting an allergy all the time. And then I started getting really bad fever spikes, and the next day I was unable to get out of my bed. So my friends got me hospitalized, and I needed fluids for about a day. But after that, I started getting better, and then I came out to be positive, which uh, surprisingly, like most of especially my department and a lot of residents also in my hospital, we in my department about 70 to 80% have gotten infected, and by the time I got infected, at least 50% had gotten infected. So I was not exactly surprised that I was COVID positive. It's still I think I was more worried for telling my parents about how they would react to that, because it was my mom was also already freaking out a lot.
Mm.
But yeah, it's a little scary when it happens, especially at least to me, because I had a little bit of a hypotension when I got infected. So that was my first day was bad. Especially it's the first time that I've gotten sick without people I know with me. I think that's the really scary part of COVID, is that you don't have anyone with you. You don't have any relatives with you. You don't have any friends with you. You're all alone in the hospital, and it's just between someone who's wearing a PP and talking to you and checking your temperature. That's the only contact you get with other humans, which I think is really scary. And I can't even imagine how, like, I was able to walk and talk, and I was able to eat food on my own and all, but I can't even imagine how patients who are not able to do that are managing on their own without having their relatives to handle it, because being sick is all about having people to take care of you.
Yeah.
But then I had my ward ended up having a lot more of my batchmates, because, like I said, by then a lot of my residents, a lot of my co-PGs, I must say that my department has worked non-stop, and about 80% of them have already gotten infected. and it's like a growing trend that people get infected, other people who recover take their place, and then they get infected, and then the other patient takes the place. It's actually a very it's a ridiculous float. It's a ridiculous situation to be in, but unfortunately, that's how it is. So all of us have already gotten infected once, and we know how it is. So I was hospitalized for 16 days, and
Wow.
I was symptomatic in that only for about 5 to 6 days. After that, I was feeling much better, but it takes time for the swab to turn negative. So uh, the first 2 days were bad. After that, it was pretty much, it was like a regular day of just having to be stuck in an isolation ward for 16 days, which was a little bit tedious. But it's
So
okay.
how did your parents react? Like,
Oh,
they were in Bangalore, no?
my mom cried. My mom cried for an entire day. My dad tried to intellectualize it. He's like, "Oh, what are your symptoms? I'll tell other people to watch out for it and everything." And I was like, "It's okay. You can feel bad about it." But my mom took a while to handle and I think Nisha helped a lot with that. She handled my mom, and she's like, "It's okay. She's in a good hospital. She's being taken care of, and it's fine."
Yeah,
So
but of course, I'm sure she also must be like, yeah, like all of them must
yeah.
be so
They
like,
all were, and I think I was more freaked out by thinking about how much tension my mom was in at that point of time. And I know all of my friends were facing the same situation, so
no, but
it was a little
you know
scary.
what word? No words, no thank you. Like the words we use, like Corona warriors, but you guys are warriors and
Mm.
fighting so much. Thank you so much. What can one say? Like this is overwhelming. Thanks a
And
lot.
so, yeah, it's, you literally have to fight the virus. I think I must, applaud all your efforts. And, I mean, it's not a very easy thing to go. And I think what you said makes a lot of sense. Many times you don't understand the gravity of the situation, right? When we see people outside, just putting a mask on their chin, and they're, trying to
Yeah.
resume their lives. But when it hits you yourself, and you see yourself alone for days, you don't know what's going to happen tomorrow. You start thinking about everyone around you. I think it's a very, very scary situation. And we are underestimating this disease a lot.
We
and
are.
and one of the things that kind of concerns me about this particular virus is that the rate at which it's mutating. And there have been a lot of documentations of reinfections that people have had. Has anyone from your department or people around you been reinfected?
One of my seniors got reinfected. He didn't. He was symptomatic, contrary to the some people have said that people are not don't get symptomatic the second time, but he was symptomatic. And we've had a couple of patients. We've had two patients actually who have gotten positive again.
Again,
So that's really scary. Yeah, all of us got a very bad
no,
hit of.
that is
Yeah, we
concerning.
were scared when he heard
Because
that.
that loop that you were talking about, right? That someone in your department gets it, then you get it, and then other people get it. And then that makes it a very difficult disease to get it out of
It's
your
a
environment, right? It,
exactly. It makes the future very scary. It makes the future absolutely blank. Like I don't see how we are going to
yeah.
get out of this loop with
And
this happening.
I think it's really questioned our principles of understanding virology, because I have never always assumed that once you are infected with a particular virus, you're immune for it. That's how we do it for influenzas and all of that, right? But I think we have not seen a virus that mutates this fast. And
Plus the number of strains that
I-
the virus has, which just makes the possibility
and this also makes the probably the use of vaccinations questionable. What are your thoughts on
questionable.
the vaccine usage, if you have any?
Uh, not much, but I was also questioning it, because if we have these many strains, and if there was no chance of and even the immunity that they said was there before lasted only for 2-3 months, so I don't see how a vaccine is going to help very much.
Yeah.
But yeah, not very clear about.
You know, I
Okay.
want to ask both of you, Dr. Jagdish, you and Dr. Usha, you know, the role of empathy and the role of, empathy when it comes to medical profession and for doctors. Like you said, that one of the most significant things that stands out is that patients are alone, right? And if today someone, God forbid, passes away, then also it is an alone process. The whole process is very alone, isolating. How do you, both of you are doctors, and sometimes I feel, and this could be my opinion, that doctors sometimes are not able to, maybe because they're seeing so many patients, they're not able to bring that kind of empathy. But I don't want to generalize. How do you look at patients, and how do you look at this whole empathy, compassion as a doctor when you're dealing with patients?
Okay, so my experience in these, especially I'm talking about these past three, 4 months, was that in the initial part I was very frustrated. I was a little irritated that I was working in the hospital, in this hospital where patients seemed to be coming in from almost everywhere. We were overloaded with COVID patients, non-COVID patients, and at that time, I personally had one during my emergencies. I had a 19-year-old boy who came to the emergency, and he had been quite a lot of at that point in time every hospital was not most of the hospitals weren't taking in patients, so they were just sending him from one hospital to the other. So he had been to around 10 hospitals before he came to our hospital, and he didn't have any signs. He had tubercular adenitis, so he had a tubercular infection with suspected adenine insufficiency. So he was almost on the brink of death when he came to me. He was his BP was almost he was his blood pressure was not recordable, his sugars were low, and it took 5 minutes and two injections to get him to recover from that. So what really scared me was that if he hadn't come to me in 2 minutes, a 19-year-old boy who walked out of my ward 3 days later, he would have died. And that made me really thankful that I was in that situation and I was able to do something about it. And after that, I started looking at it as an opportunity, and then I started feeling like it's not that bad a thing that I'm actually in this situation, and I didn't mind. Other than that, my experience with getting COVID and experiencing the whole isolation, it made me feel so much more empathic towards the patients who are admitted in the ward right now. Like we had 60, 70-year-old patients who didn't have anyone, because a lot of the people from the background who the patients in my hospital came from, they didn't have relatives who wanted to stay with them, because they heard that once you have COVID, you're pretty much doomed. So a lot of them were just dumped in the hospital and gone. And that was a really sad situation, because you don't have anyone to provide you with food. I mean, the hospital provides with a lot of things, but after a certain time, they just started. I felt really bad one day. I spent about 5 minutes just trying to feed this one lady juice, because I was like, if someone was there with me and trying to help me out when I was sick, then I would have felt really happy when that happened. And there were people to help me out at that point in time. So I think this has brought out a complete different level of empathy for people and compassion. But yeah, learned a lot of lessons.
It's social distancing, but I want to hug you. Like, this is so much.
I want to hug you.
No, this comes from so much of gratitude, like so amazing, because this is very tough time, and especially like, with relatives, and how do you deal with it? And doctors are the people you are, they are the gods, right? Like, who are with you. So but again, Dr. Jagdish, to you also, I want to ask you this is, do doctor, like, is in your profession, do you have some code, like, oh, you don't have to be very close to a patient, you have to behave in a certain way? Because sometimes some doctors, very senior doctors, I've seen they are very reserved also.
Yeah, no, although there is definitely an ethical code of conduct which we call transference and cross transference, where as a professional you don't cross certain boundaries, but that does not limit you from being empathetic. I think as a part of a medical profession, as a doctor, empathy is a very important aspect. It's also taught to us. However, sometimes it becomes a little hard to practice, primarily because I've talked about this before, and it's a bit philosophical, because you always look at your work non-emotionally. Like, for example, if you're working, you're typing, you're working on a computer, you're usually not emotional to it, right? And for a doctor it becomes challenging, because your work is with human beings. So somewhere it becomes a case, it becomes subject, it becomes disease, it becomes diagnosis, it becomes numbers. Somehow, you don't want to do that, but somehow it becomes like that. And at that point of time, as you're working, the empathy fades away when you start looking at it as work. But when you start looking at it as someone your own, then your empathy comes in and the work goes away. And somehow it's a very tough balance in a doctor's life. I've had to be on both sides of the spectrum. What I do now is I definitely, the one thing that I've learned is always inform the patients and the relatives about anything that you are thinking. And one of the things that I do is I take extra time, and this is one thing I even tell in my outpatient setting, is that I am not going to work like a clock. If you got a 15-minute appointment, but if this patient needs 30 minutes, I am going to spend 30 minutes with the patient, but I'm letting you know that, okay, that this is going to take more time. You want to go get a coffee, you can go and come there, but I cannot cut short that. And that's very challenging now when I'm doing online consultations, because online consultations sometimes automatically go off at 15 minutes, and the next patient suddenly appears in front of you. You didn't have a chance to say your advice, but when you're sitting in a chamber, you can do that. And that's why, I feel every patient is different, every disease is different, everyone needs a different level, and you need to be sensitive to see that. I've started to see that, and I try to practice it as much as possible. And I'm doing things which I earlier never used to do. If I don't know something, I just tell them I don't know. This is not my expertise. I recommend you to someone else, rather than just trying out and doing something. I just tell them that if I'm going to try out, I'm going to try out with your consent. But I don't know this. Or if somebody says, will I recover? If I don't know, I will say, I really don't know whether you recover or not. This is a very new disease. And this is what I have to do when people who think they have COVID ask me, do I have COVID? I'm like, I don't know. I'm on the phone on the other side. It sounds like you do, and you should probably do these things. But that, that's not going to change your course of treatment. Just like how Dr. Usha was saying. And that's something we need to understand. That patients, when they think they have COVID, they immediately jump to getting it tested. They want to know for sure. They subject themselves to more risk even if they didn't have it. Where the parameters that we should be looking at are more symptoms, like these kind of things: dropping saturations, your breathlessness, your functionality. Those should be the markers for care, and the rest should be managed at home or at a facility. That itself will reduce a lot of exposure and re-exposure, which is a very scary part of COVID-19, is you can get it and get it again. And that is something that will ensure that it won't leave us for a long period of time. So
I want to ask both of you now here, Doctor, is today I just spoke an hour back to Dr. Not to Doctor, to just an hour back, I spoke to Kiran Mazumdar Shaw, and there's this new medicine she was talking about, and she said that today there was a webinar with lots of doctors from across the country, and they said that actually now 500 patients have recovered, and there's this good result. Have you heard of this drug from Biocon, and what do you have to say about it?
I've read about it in the paper. I know that the Drug Controller General of India has given the clearance, and that it is being used. And I'm really hopeful that it's a promising drug and helps. But also, having said that, I have heard this for almost every drug that has been questioned till now. Anything that starts, initial data is so good, and then I don't know, the virus mutates or a different strain comes or a different profile comes, and it stops working. We've heard this for steroids, we've heard this for HCQs, we've heard this for remdesivir. I mean, what other condition have we been talking about so many drugs, right? And the reason why we talk about them is they do work on some cohorts, they do have work on some people in some environments, but then they don't work consistently. And I really pray that this one works consistently, and we start having, just like for H1N1, we have Tamiflu, and that's it. That's oseltamivir is our treatment, and that works even today. If you have someone with H1N1, they will respond to that. But we are not able to get that kind of an answer for COVID-19, and I think it just is that you have to look at every case in a very different, permutation combination, and offer something customized. That's what I think has to be done for this. And I hope this drug that Biocon has developed is the single dose a drug answer. But the trends have been that something works in the beginning, and then somehow it doesn't work consistently. And I hope that doesn't happen here.
Yeah. Exactly. I think what you said about the customized, every individual patient getting their own treatment in this disease is very important, because everyone presents with their own symptoms and their own complications. And even exactly about the drug, my thoughts exactly that everything is proving out to be like, there's one study that says it does, there's one study that says it doesn't, and it's so inconsistent that no one, at the end of the day, everyone's clueless about how to figure it out. So I really hope that helps as well. The drug turns out to be a success.
And now I want to ask both of you, and we'll end it because we have taken a lot of time of yours also, Dr. Usha and Dr. Jagdish. Thank you for coming at such a short notice. I want to end by asking both of you two questions. One is that, this is a pandemic which has taken the world over, and we keep seeing, on CNN, I see what's happening in US, and the conversations with the doctors. On BBC, you see what the doctors and people are talking in UK. And in Europe, I want to understand, when it comes to India, are we at par, or there is something missing, or do you think we are better? Or, how do you look at the medicine, especially related to the handling of COVID-19? How have we done as a country? And both of you tell me, how do you see this? And then moving forward, if you have to tell everyone watching this as doctors, because I again go, doctors for us are gods. So if you have to tell us that people are very scared right now, everyone is scared today. If you have to tell them how should they be dealing and living their lives right now, what would you tell them?
Yeah. Okay, I can go first. To the first part of your question, I think, sorry, the first part was on,
the medicine community and the doctors and the hospitals. How are we as compared to other places in the world?
I think we have done fairly well, and I think we've done better than many countries which we thought were much better with their healthcare infrastructure. To be very honest, I'm not trying to be very patriotic over here, but I think we are very resilient breed of doctors. If I must say, we adapt very quickly. We are very much on our toes with our research, and I've seen that. I've seen a lot of my colleagues work. I've worked myself in various hospital settings, and we're very quick to adapt. And many hospitals are flexible. Some larger countries and larger infrastructures, the reason why they've struggled is because they're not used to rapid changing. They have a protocol and they stick to it and they adhere to it, which is good many times. But at times like pandemics, where you have a very misunderstood or poorly understood virus that is constantly changing, you need people constantly trying things. And the word jugaad comes from India, and we constantly try in the best interest of the patient to save them at all points of times. And the reason why we have so many different ways people are approaching, because people are constantly thinking and trying. Our healthcare system is constantly thinking and trying. And like Dr. Usha mentioned, they had a lot of chaotic situation. They figured out a way, and we always figure out ways. And if you look at our numbers, the infectivity credit goes to the virus, but the way we control our mortality rate is reflection of our healthcare.
Yeah.
And it's also a reflection of we as a community and whatever we have done. Many people might criticize the lockdown, and many people might criticize that we are not taking it seriously. Of course, there are some people who are still callous about it, but a vast majority of people I've seen are following protocols, and we are in a very different place right now. Like I can see people asking, why you're not wearing your mask, or cover up your nose, or I'm not going to go out, or I'm going to stop doing some things. And there are some behavioral changes that are happening. Our healthcare infrastructure is not where it should be, and it's very diverse, especially with the rural healthcare and the urban healthcare being quite different. But since this is a disease that was imported, as I would say, and it has hit the metros first, I think we are able to manage it from that level. If this is something that had come down up from the community, it would have been a very, very difficult thing to manage. And even though, there is a lot of controversy over community spread, and it probably is, but we are still in a much better place than where we could have been, if we were somewhere else. There have been some innate protecting things also, and all of that. And I think I can also answer the second part now before Dr. Usha says, is that my advice to everyone is, even though it's a scary thing, but it's also important to ensure that you distance yourself from the main risk factors. And this is an airborne disease. In the only way it will come to you is if you inhale it, or if it comes close to your mouth and airway, and that is the only single point of entry. So you need to please wear a mask whenever you go out, even if you think whether there is or somebody has it. Don't think your relative is there, so they won't have COVID is not doing any preferential thing to your relative. Okay. And many people find it odd and awkward to tell their relatives to wear a mask. Ye to apna banda hai yaar, koi baat nahi, tu bina mask ke kar le. I'm like, kaise? How do you know he's not an asymptomatic COVID-19 carrier? How do you know that? Have you done a test? Can you see the virus? You can't, right? So you need to wear it even with your parents, with your sister, with your kids. If you are outside, wear a mask. If you're inside the home in a closed environment, do not wear a mask. Maintain 6 feet distancing. This is so much more affordable and simpler way to keep yourself safe, rather than going through an ordeal of you don't know what will happen to you and your family. And I think that is just, the virus is tough to manage, but if you follow simple things consistently, which I know is difficult, you can save yourself and your family, and you can stop this whole cycle. And don't be hesitant about telling people to wear the mask. They just have it there over here in the chin like an underwear. I make a lot of jokes, and then that is not going to help you. In fact, it's going to take your skin infection and bring it back to your nose as well. So don't do that. Be vocal about wearing the mask. Be vocal about that, and don't think about your relative, and don't think about the hesitancy of telling things. It's your safety, and your safety is also your family's safety. So I would like to say that. And for the medical fraternity who are listening to me, I think there are some very good points over here about triaging people based on saturation and pulse rate, and trying to divert as many people who are less symptomatic to do home care, and only take the most important people into either NIV, or high pressure airway, oxygen, or if worst case scenario, into ventilation. And I think the drugs that have been working over here in Mumbai have been steroids, heparin, and the tocilizumab. But otherwise, we are hopeful with other drugs as well. So that's my summary.
Wow, you summed up so well, Dr. Usha.
Okay, so that was summed up. Actually, that's most of what I wanted to say as well. What I wanted to add was that I think India's made a very good progress in terms of. I never expected people to be able to provide these many PPEs for these many months, and I think there are a lot of countries which don't even do that right now. And a lot of my friends working in other countries have been feeling so hopeless because they haven't been able to get enough PPEs to work, even though they've been in direct contact with COVID patients very frequently. So I think the fact that our country and our healthcare has been able to provide these many facilities this fast and be able to implement it at every single hospital, from the smallest to the highest, I think that's a commendable achievement in itself. And I think people in general, like Sir said, that I think for the amount of education, for the amount of proportion of people who are educated in the country, people who are actually listening to our advice is very high. I think we've heard a lot about people in the US who don't care enough about all the advice that's been said. And for the number of people who are educated in our country and to be able to listen to all the advice and actually stay at home, I think that's a pretty big deal.
Yeah. I think freedom to breathe is more important than freedom to speech right now, actually.
Exactly.
Yeah, no, Dr. Usha, thank you so much. Very proud of you. And I'm sorry, I'd have to bring that. I don't want to, but I have to. I can't not do it. I have to bring that gender lens. I feel so proud to see such a young girl doctor and being so relentless and doing so well and loving. And you bring empathy. It also brings. I'm so impressed and I'm so thankful. Thank you so much. Please take care and all the best on your mission, because you are helping save so many lives. Thank you so much. Thanks a lot.
Thank you.
Thanks
Thank
a
you for
lot,
this
Dr.
interview.
Usha, from me to all of your team members who are with us together in this fight. And I think you've been a survivor and a strong warrior. And I hope you continue that and continue being safe. Because the war is not over, and we need to be smarter and keep moving ahead with the learnings and start battling this virus and hit it out of the park. So that's something that we need to do. So thanks a lot from my side as well.
Thanks a lot for the opportunity, guys. I love talking about this, and it's just so much emotion in one time. I'm so glad I got to get this all out into to share it with you guys. Thanks for the experience, and love meeting you guys.
We'll keep talking to you. We'll keep calling you and we'll keep having conversations.
I would love to do that.
Thank you. Thanks a lot. Thank you. Thank you, Dr. Jagdish. You make it all the time so beautiful and special and powerful. Thank you. Thanks.